This podcast is sponsored by Zoll LifeVest. Zoll has continuously improved LifeVest for over 20 years, leading to a median real-world wear time of 23.4 hours per day and an AI-enhanced algorithm that delivers zero median false alarms at 90 days. The newest LifeVest garment is lightweight, breathable, and preferred by patients for its comfort. Learn more at lifevestinnovation.com.
Worldwide, cardiovascular disease affects the lives of hundreds of millions. Dedicated CardioNerds everywhere are working hard to fight this global epidemic. These are their stories.
Hello, CardioNerds, and welcome. We are in Rochester visiting University of Rochester Medical Center and super stoked to be talking to Dr. Lefan He, Dr. Sina Omran, Dr. Neil Gupta, and we're going to be talking about such an important topic in cardiology. But before we start, team, why don't we introduce ourselves? Go ahead.
Hi, everyone. I'm Lefan. I'm a PCWP first-year general cardiology fellow here at the University of Rochester. I grew up in the great state of New Jersey and stayed there at Rutgers Robert Wood Johnson for medical school. I then completed my internal medicine residency at Dartmouth Hitchcock Medical Center. Now I'm super excited to be here at the University of Rochester completing my general cardiology fellowship. I'm interested in general and interventional cardiology, and in my spare time, I enjoy running and cycling, and I recently picked up my guitar again after a long hiatus.
My name is Neil, and I'm the Chief Cardiology Fellow here at the University of Rochester. I actually grew up in Rochester and didn't go too far for medical school at the Jacobs School of Medicine at the University of Buffalo. I did my residency in internal medicine here at the University of Rochester, and I stayed for fellowship. I'm interested in general cardiology and echo. I'm happy to say that I'm staying here as faculty for the next academic year. In my spare time, I enjoy exercising, cooking, and hanging out with my family and friends.
Hi everyone, my name is Sina, and I'm a third-year general cardiology fellow here at the University of Rochester. I grew up in Toronto and went to med school at Vanderbilt University. I did my residency in internal medicine at UPMC in Pittsburgh. I will be sticking around with the U of R for interventional cardiology fellowship later this year. And this is also where I'm supposed to give a shout out to two of the cath lab nurses here who love this podcast, Dana and Janine. In my spare time, I like to cook and listen to podcasts, albeit more of the true crime flavor than the medical kind.
Guys, that's awesome. Thank you, and congratulations to all the transitions that you guys are going to be having in your career right now. Super exciting times, and love the shout out. So now let's get dirty and talk about some cardiology. But before we do that, can you take us to one of your favorite places in the city so we can settle down and get ready to learn?
Well, absolutely. Well, seeing that it's almost the summer, I think we should spend a nice day out in the sun sailing and paddleboarding on Lake Ontario, followed by grabbing some drinks and dinner by the waterfront.
All right, terrific. I've got my sunscreen lathered up and ready to go. So why don't we dive into your case?
So we have a 63-year-old man with a past medical history of hypertension, hyperlipidemia, and active tobacco use who presented overnight to our emergency department with a chief complaint of sudden onset shortness of breath. The patient states that he was in his usual state of health when he suddenly felt short of breath earlier this afternoon. He denied any chest pain or pressure in the hours to days prior to onset of shortness of breath, but did notice some mild chest pain described as mid-sternal, non-radiating, and non-exertional that began shortly after he began feeling dyspnea. His history, again, is only significant for hypertension, for which he takes amlodipine 5 milligrams and hydrochlorothiazide 25 milligrams, hyperlipidemia, for which he takes atorvastatin 20 milligrams, and GERD, for which he takes omeprazole 20 milligrams. He has never had any surgeries, has no allergies, and no family history of coronary artery disease or sudden cardiac death. Unfortunately, he does still smoke tobacco, but denies any other recreational substance use.
What would be your differential for sudden onset shortness of breath, Lefan?
The differential for shortness of breath is quite broad, as you can imagine. I like to distinguish, however, between acute versus chronic causes of shortness of breath. Fortunately, the differential for acute shortness of breath is a bit more narrow, and I like to break these down into two buckets, cardiac and pulmonary. The big cardiac causes of sudden onset shortness of breath include acute coronary syndrome, heart failure, and pericardial tamponade. Meanwhile, pulmonary causes of acute onset shortness of breath include, of course, pulmonary embolism, as well as pneumothorax, bronchospasm such as from COPD or asthma, and pneumonia.
Now, based on the patient's initial presentation, what do you think the likelihood of acute coronary syndrome is?
That's a great question, Neil. I actually think a pulmonary embolism would be higher on my differential, just based on the very limited information we have so far. Acute coronary syndrome is certainly possible, but the presentation of sudden onset shortness of breath, followed by somewhat mild chest pressure, would be more atypical of ACS. But now that we've gone over his initial presentation, let's refine our differential diagnosis a little more. Sina, can you tell us about the patient's vitals, physical exam, and labs?
Sure. The patient is tachycardic at 130 beats per minute with a blood pressure of 126/76. He is afebrile at 95.9 Fahrenheit. His respiratory rate is 20, but he's already on non-breather mask with a flow rate of 15 liters per minute and 100% oxygen, satting 98% on this. He later had to be placed on BiPAP. His exam shows a patient in moderate distress with an NRB mask on and diffuse crackles. His cardiac exam is limited by significant tachycardia with no obvious murmur appreciated. He has no pedal edema and is warm. GI exam shows a soft, non-tender, non-distended abdomen, and he has no focal findings on neurologic examination. His BNP is fairly unremarkable aside from a creatinine of 1.1, which is at his baseline. And his CVC is most notable for a white count of 13. His troponins are elevated and dynamic at 570 to 801 nanograms per liter. At our institution, 14 is the upper limit of normal. And NT-proBNP is 948 picograms per ml, which is mildly elevated for our assay, with 900 being the upper limit of normal here. D-dimer is elevated at 2.2. ABG on NRB shows pH 7.33, PCO2 of 38, PO2 of 82, bicarb of 19, and an arterial lactate of 2.2, upper limit of normal being 0.8 millimoles per liter here. Lefan, can you describe the patient's initial chest x-ray and EKG?
Sure, Sina. So this chest x-ray is a frontal projection, and immediately we can see diffuse bilateral interstitial and airspace opacities. While there's also cephalization of the pulmonary veins, we do not see enlargement of the cardiac silhouette. Overall, this chest x-ray clearly points to extensive pulmonary edema. Now to go over the patient's EKG. We can see the patient is in sinus tachycardia at about a rate of 130 beats per minute. There are T-wave inversions in lead 3 and AVF, as well as about 0.5 to 1 millimeter ST elevations in lead 3, and about 0.5 millimeter ST elevation in lead AVF. We can also see a deep Q wave in lead 3, but it should be noted that this can be a normal variant. So certainly we're worried about ischemia given this EKG, though it does not quite meet the STEMI criteria. Now, Sina, how do these initial labs and diagnostics change your differential diagnosis, and what would be your immediate next steps?
The chest x-ray and BNP, along with his dyspnea, are suggestive of congestive heart failure as the etiology of his shortness of breath. Although it's interesting that he has no edema on exam, which starts making us think about maybe an acute LV dysfunction process or left-sided valvular issue as the etiology. The highly elevated and dynamic troponins raise a question of an MI as one possible cause, although the ECG is not fully consistent with STEMI, as Lefan pointed out. Flash pulmonary edema from hypertensive crisis can present similarly, although he is not hypertensive at this time. Pulmonary embolism can be considered as well given the elevated D-dimer, but the level of troponin elevation is a bit atypical for this, and the level of hypoxemia can be explained by the pulmonary edema without invoking PE. The elevated lactate suggests hypoperfusion, which any of these pathologies can lead to. In a case like this, where we have discrepant information and a presentation that is outside typical norms for any one pathology, a point-of-care ultrasound can be helpful. My threshold for obtaining a CTPE protocol is also low in these situations, which is what the evaluating team ended up doing. Neil, can you tell us what we saw on CTPE?
Our CTPE chest did not show any evidence of pulmonary embolism or aortic dissection. Is there anything else you can do at bedside to help hone your differential, Lefan?
I think at this point, we should get a point of care ultrasound or POCUS on this patient, as we are worried about decompensated heart failure. This was done, which showed quite dramatically a hyperdynamic LVEF.
That's a great idea with the POCUS, Lefan. Good job. Obviously, as this modality becomes more available and with handheld machines becoming more advanced, we should really be incorporating this into our daily practice. Do these findings help narrow your differential, Lefan?
Oh, absolutely. And that's a great point you make, Neil. As bedside POCUS is incorporated more and more in medical training, we all should try to do at least a quick POCUS on most of the patients we see in cardiology. When we see a hyperdynamic LVEF, in combination with evidence of ischemia on ECG and elevated troponins, our concern now is an acute myocardial infarction resulting in a possible mechanical complication.
This is an amazing conversation, and I definitely want to just jump in and add to this idea of POCUS. POCUS is such a valuable tool in this particular scenario where you really want to find out what's going on under the hood. And I think when you're using point of care ultrasound or any echo in general, you want to have two kind of philosophies. One is to be systematic and approach the cardiac exam in a way that's thorough and the same every time. And that will allow you to capture all of the images that you think are going to be helpful for most patients and not miss something by jumping around in the exam and anchoring on a particular diagnosis. But at the same time, before you approach the patient with POCUS, you should ask yourself, well, what do I expect to see from this patient's clinical presentation? Like, what am I going to be seeing? So I have a patient here who is not doing well. They're in frank pulmonary edema. I may expect to see really reduced left ventricular function. And when you put that echo probe on them and you see this hyperdynamic function, as you guys described, right, that is telling you a very important piece of information. You're saying this hypercontractile left ventricle does not match this patient's overall clinical presentation. Something is going on here. And I may not have captured all of the heart yet on the echo imaging, but I'm now suspicious that while the left ventricle is showing us an elevated ejection fraction, much of that blood may be going backwards. In fact, we know where it's going. It's going back to the lungs, resulting in this crazy presentation of pulmonary edema and contributing to the patient's primary symptoms, which is a respiratory complaint. And everything is starting to make sense. And so I love that you now pivot to say, well, is there a mechanical complication going on here such that we are not having adequate forward flow out of the LVOT, out of the aortic valve and into the aorta, perfusing the body, but rather going backwards perhaps. And this may lead us to the diagnosis for this particular patient. So I just love how you were able to recognize what you were seeing on POCUS and pivot to further the care of this patient. One last point about POCUS is sometimes in the moment, we are not able to capture everything because we have to tend to the patient's clinical needs. They're hemodynamically compromised. But sometimes when the dust settles, we can get a formal echo, and that kind of will fill in the pieces and the gaps and help us recognize what is going on with the patient and guide next steps. So did you end up getting a formal echo after this point of care ultrasound?
Yeah, absolutely. Thank you for asking. And what I would say is what we first noticed is a hypercontractile LVEF of 80%, kind of like what Lefan had noticed on his POCUS, with a PDA distribution wall motion abnormality. There was normal RV size and function with an estimated mildly elevated RV systolic pressure of 40 millimeters of mercury. There was noticeable papillary muscle rupture with a flail anterior mitral leaflet with posteriorly directed mitral regurgitation. The regurgitant volume was 77.5 milliliters with a regurgitant fraction of 64%, based off of an LV end diastolic volume of 160 milliliters and an LV end systolic volume of 39 milliliters.
Wow, a flail mitral valve leaflet. What a dramatic presentation. It's important to remember that due to the rapid equalization of pressures between the LA and LV, approximately 50% of patients with moderate to severe acute mitral regurgitation have no audible murmur. Also, while mechanical complications such as papillary muscle rupture typically occur in STEMIs, these complications can also occur, albeit much less commonly, in NSTEMIs. Now, Sina, our patient's blood pressure is starting to fall too. What do you think should be the immediate next step here?
The drop in mean arterial pressure reflects poor forward flow given the severe mitral regurgitation. After-all reduction is your friend here, but the hypotension is going to limit medical therapy. As such, this patient needs mechanical circulatory support, with balloon pump being the preferred modality for many patients, given the simultaneous after-all reduction and improved cardiac perfusion that this device provides. Given that this is likely caused by an MI, the patient should also have coronary angiography and right heart catheterization to guide next steps. The cardiac surgery team should also be contacted sooner rather than later so the patient can be evaluated for mitral valve repair/replacement.
And that's exactly what happened next. Sina, can you describe for us what was seen on cardiac catheterization?
Definitely. So for initial stabilization in the ICU, the patient had a balloon pump placed at bedside via the right femoral artery. He was then sent down emergently to the cath lab. Right heart catheterization there showed CVP of 9, PA pressure of 55/19, and wedge pressure of 17, with a cardiac index of 1.4. This was with 1-to-1 balloon pump support. When the balloon pump was turned off temporarily, the wedge tracing showed large B waves to 40 millimeters of mercury, which again confirms severe mitral regurgitation. Given that the low cardiac index, despite IVP support, suggested that the IVP support was insufficient, the patient was upgraded to Impella CP, with subsequent improvement of cardiac index to 2.2. Now that the patient was more stable, we proceeded with coronary angiography. We start out with views of the right coronary artery. There's an ulcerated plaque in the mid-RCA, which is not flow limiting. It's about 60% in stenosis severity. The patient has a right dominant system. The left main and left circumflex look pigment and without obvious disease. The mid-LAD, however, has a very tight tubular lesion right after the takeoff of the first diagonal, with TIMI-1 flow beyond it, best appreciated in the LAO cranial view. We also see faint left to right collaterals, so there might be a distal RCA obstruction that we're not fully appreciating here. The patient was then taken for a TEE. Neil, can you describe what we saw?
Of course, our TEE was performed at bedside in the CVICU. The LV function was normal with basal to mid inferior lateral wall motion abnormality. The posterior medial papillary muscle was ruptured with small segments of the anterior mitral leaflet of the A2, A3 scallops, leading to mitral valve non-coaptation. There was severe posteriorly directed mitral regurgitation with systolic flow reversal seen in the pulmonary vein. The vena contracta width on the color Doppler measured at about 1.1 centimeters. The impella was positioned approximately 3.2 centimeters from the aortic valve annulus as well.
Neil, now that we have visualized our flow mitral leaflet on both TTE and TEE, can you describe for us what are the echocardiographic parameters of acute mitral regurgitation?
Great question, Lefan. There's actually a lot to unpack here, so please bear with me. Typically, patients with acute severe mitral regurgitation are really, really sick. So proper recognition and diagnosis is absolutely crucial. Echo parameters used to diagnose acute MR opposed to chronic MR are actually pretty similar. However, there are some ways to help differentiate the chronicity of the MR. First, the clinical presentation is so crucial in these patients, as they usually have some inonce shortness of breath from pulmonary edema, and they usually are hypotense, which is usually a marker of cardiogenic shock. Patients with chronic MR typically have an insidious onset of symptoms over time. Chronic MR is also associated with the left ventricular and left atrial dilation. With acute mitral regurgitation, the heart doesn't have time to remodel, and these chamber sizes are usually normal. Fairly often, patients with acute MR have a hypercontractile alveoli, as blood can now travel to a low-pressure left atrium opposed to the aorta. Also, a flail mitral valve leaflet or papillary muscle rupture is usually specific for acute mitral regurgitation. There are several quantitative factors that we look at with echo, which include mitral valve pathology, color Doppler, regurgitation flow, as well as continuous wave Doppler. Echo parameters of severe mitral regurgitation include a large regurgitant volume of greater than 60 milliliters and a regurgitation fraction of greater than or equal to 50%. The regurgitant volume is the amount of blood that enters the left atrium during systole from the left ventricle. This is obviously abnormal. This is because flow will follow the path of least resistance. So we prefer to enter a low pressure left atrium opposed to a high pressure aorta. So considering a normal stroke volume is 50 to 100 milliliters, a regurgitant volume of 60 milliliters is quite a lot. Regurgitant fraction is simply the ratio of blood that enters the left atrium divided by the total amount of blood that the LV pumps out. So for there to be severe mitral regurgitation, at least 50% of the blood that is pumped from the left ventricle is actually going backwards into the left atrium. This may be useful in acute MR when the LV is not dilated and volumes actually aren't increased. Color Doppler is another extremely useful tool as it helps show the direction of mitral regurgitation, whether it being posterior, anterior, or central. If there is a pathology involving one of the leaflets, the color flow is usually directed in the opposite direction. Much like our patient here who had a full anterior leaflet, his jet was directed posterior. Typically, severe MR has a large color Doppler, which usually encompasses at least 50% of the left atrium. But this may not be the case in patients with very eccentric jets. Additionally, color Doppler usually allows for the identification of flow converging which is typically referred to as the proximal isovelocity surface area, or more simply put, PISA. This can lead to the calculation of the regurgitant volume and measurement of the effective regurgitant orifice area, or the EROA. This is essentially a measurement of the area that the regurgitant flow travels in. So the bigger the hole, the bigger the leak. An EROA of greater than or equal to 0.4 centimeters squared is associated with severe mitral regurgitation. Furthermore, a PISA of greater than or equal to 1 centimeter with a Nyquist limit of 30 to 40 centimeters a second is associated with severe MR as well. Lastly, a vena contracta is a measurement of the smallest portion of the MR jet, and a value of greater than 0.7 is a marker of severe MR. Continuous wave Doppler also helps us diagnose the severity of mitral regurgitation. The CW can be traced and used to calculate the regurgitant volume across the mitral valve with the application of the continuity. Assessment of the pulmonary veins is also so crucial. The atrium are in diastole during ventricular systole, so blood flows from the pulmonary veins and enters the left atrium during systole. Severe mitral regurgitation causes blood to reverse, and now blood leaves the left atrium and enters the pulmonary veins during systole. This is typically referred to as pulmonary vein systolic flow reversal and is usually pathognomonic for severe mitral regurgitation.
Thanks for that incredible explanation, Neil. I know I definitely will have to go back to listen to that segment again just to make sure I got everything. Sina, can you tell us about the pathophysiology of papillary muscle rupture, and how can this be explained by the patient's left heart catheterization findings?
At the risk of oversimplifying things and upsetting anatomy professors throughout the country, the normal left ventricle has two papillary muscles called the anterolateral and the posteromedial papillary muscles given their locations. Each papillary muscle has chordae connecting it to both leaflets of the mitral valve. On average, around 62 of such chordae per papillary muscle. The papillary muscles actively contract just before the rest of the ventricle, and by pulling on the chordae, prevent the mitral valve leaflets from prolapsing when the left ventricle contracts. If the blood supply to the papillary muscle is abruptly cut off, and there is little to no collateral flow to supply it, as is often the case in a STEMI, the cells in the papillary muscle become necrotic, and in 2 to 7 days, the structural integrity of the papillary muscle is reduced. If the LV function is preserved or even hypercontractile, the movement of the myocardium, compounded with a tension from the chordae, exerts high shear stress on the dysfunctional papillary muscle, leading to a complete or partial tear depending on the situation. In fact, most cases of papillary muscle rupture are associated with a small amount of ischemia in the left ventricle overall. The posteromedial papillary muscle receives all of its blood supply from the PDA in most people, while the anterolateral papillary muscle receives it from the LAD, usually the first diag, and the left circumflex, usually the OM1. As such, posteromedial papillary muscle tears are 6 to 12 times as common as anterolateral. But again, given how the chordae connect to the leaflets, this can still affect both leaflets of the mitral valve. Without the papillary muscle tethering the leaflet can prolapse during ventricular systole, causing severe mitral regurgitation. Additionally, given that many of these patients also have RV infarction from an RCA obstruction, the dysfunctional RV can become overwhelmed by the regurgitant flow, leading to a death spiral. In this particular patient, while we do not see obvious RCA obstruction, the presence of left to right collaterals, as well as basal to mid infralateral and inferior walls hypokinesis on echo, suggests that either a small vessel from the RCA was obstructed at the time of the MI and no longer visible on angiography, or there was a transient occlusion of the mid-RCA lesion that has since spontaneously recanalized. It is important to keep in mind that up to 30% of STEMIs have spontaneous recanalization, and the ulcerated appearance of the RCA plaque could suggest that this was a culprit. I think it is less likely that the tight LAD lesion is solely responsible for what's going on here, although given that the LAD is feeding the collaterals, it is certainly possible that there was a multi-hit event here. I should add that other possible etiologies of papillary muscle rupture include blunt chest trauma, although that's classically more for the tricuspid valve's papillary muscles, endocarditis, cocaine abuse, and of course, iatrogenic etiologies. But it doesn't seem like any of these were the case here.
That's a very interesting proposition for the mechanism leading to this patient's papillary muscle rupture. Now that we know what is going on with our patient and also have an idea how it happened, Sina, can you take us through the management for acute MR due to papillary muscle rupture?
Ultimately, this is a mechanical problem and requires a mechanical solution. Papillary muscle rupture is one of the indications for urgent cardiac surgery in the setting of STEMI, given that it has an 80% mortality in the first week if untreated, and performing concomitant CABG as a class 1 recommendation from the ACC and AHA. However, the patient does need to be brought out of the shock state as much as possible, and this is where mechanical circulatory support has a role. This is a class 2A recommendation by the ACC AHA. While being optimized for surgery, the patient should be on aspirin and an IV anticoagulant such as heparin. Invasive hemodynamics with Swan-Ganz catheter and arterial line can also help with titration of pressors, inotropes, and diuretics until the time of surgery.
And when it comes to surgery, Sina, is there a difference between repair or replacement of the mitral valve?
It's an excellent question. While in most primary mitral regurgitation disorders, repair is preferable to replacement, papillary muscle rupture is rare enough that we have no strong evidence base to guide us. The major arguments against repair are that edema, tissue necrosis, and lack of tensile strength in the recently ischemic myocardium and papillary muscle mean that the repair might not hold and the patient will have recurrent severe mitral regurgitation, requiring repeat surgery. As such, a chordal-sparing mitral valve replacement strategy might be superior. According to one analysis of the STS database from 2011 to 2018, 79.8% of patients receiving mitral valve surgery for papillary muscle rupture have mitral valve replacement, and the rest have repair. So in day-to-day practice, it does seem that replacement is preferred. I should note that the database does not have enough granularity to make conclusions on the type of papillary muscle rupture, i.e. was it partial or complete, and a decision on type of surgery, but it does show that the patients who received replacement tended to be more in a cardiogenic shock state, have higher creatinines, essentially be more sick overall, which would suggest that these were likely the complete tear patients who received replacement.
And how about transcatheter interventions?
Given that most of these patients are very sick, often requiring mechanical support and inopressors, it would be great if there was a transcatheter solution to offer this population, either as a destination therapy or as a bridge to surgery when the patient is more optimized, i.e. no longer in an acute shock or an acute MI state. Currently, around half of all patients presenting with papillary muscle rupture are not offered surgery due to prohibitive surgical risk. As a result, there are several case reports of successful transcatheter edge-to-edge repair for these patients. But the largest trace series out of Scripps showed that while the procedural success is there, with significant reduction of severity of mitral regurgitation, 4 of the 5 patients who received the therapy still died during that hospitalization. This probably reflects the fact that these are very sick patients and they did not have many other options. Of course, even with the gold standard treatment of surgical repair/replacement of the valve and concomitant bypass grafting, around 10 to 40% of patients with papillary muscle rupture do not survive their hospitalization, which is a sobering reminder of just how much work has to be done here. Lefan, now that we've talked extensively about acute mitral regurgitation from papillary muscle rupture, can you take us through a brief overview of the other mechanical complications of acute coronary syndrome?
Of course. So the 4 major mechanical complications of an acute myocardial infarction are acute mitral regurgitation from papillary muscle rupture, ventricular septal defect, ventricular free wall rupture, and pseudoaneurysms. I think it's important to emphasize that all of these complications have relatively high mortality rates. Papillary muscle ruptures we have already talked extensively about. Ventricular septal defects occur 3 to 5 days after a transmural infarct. The clinical presentation can vary from just an isolated murmur, typically described as a harsh, loud, holosystolic murmur heard best at the left lower sternal border, all the way to cardiogenic shock. Echo will show a left to right shunt across the septum. Right heart catheterization will show a step up in oxygenation between the RA and PA, as well as an elevated QPQS. Anterior and apical VSDs are typically caused by LAD infarcts, while posterior VSDs are associated with inferior infarct. VSDs are generally managed by initiating afterload reduction, such as with an intra-aortic balloon pump, followed by urgent surgical or percutaneous repair. Next, we have ventricular free wall rupture, which presents with elevated JVD, muffled heart sounds, and pulsus paradoxus. As blood comes in contact with and irritates the pericardium, the patient's EKG can show nude ST segment elevations. As you can imagine, these cases have very high mortality rates, and the management is emergent surgery. Lastly, we have pseudoaneurysms, which, unlike the others, typically present weeks to years after infarct. Pseudoaneurysms occur when a cardiac rupture is contained by the pericardial adhesions, and it most commonly involves the inferior or lateral walls, as anterior wall ruptures are more likely to cause massive hemopericardium and immediate death. Patients usually present with shortness of breath or chest pain, but can be asymptomatic. Diagnosis involves the use of multiple imaging modalities, such as echocardiography, which can demonstrate pseudoaneurysms with a narrow neck. Once diagnosed, pseudoaneurysms should be urgently repaired due to a high risk for rupture.
So, Lefan, tell us, what ended up happening with our patient?
I'd be happy to. It's certainly scary managing such a sick patient who was deteriorating overnight. Since he presented with such significant pulmonary edema, he was immediately started on BiPAP with the positive pressure ventilation, helping to reduce his LV preload and afterload. As his blood pressures began to drop, norepinephrine was started. Cardiac surgery was consulted, and an intra-aortic balloon pump was placed at bedside. A cardiac catheterization was performed, during which the intra-aortic balloon pump was removed and replaced by an impella. The patient ultimately underwent a successful tissue mitral valve replacement and CABG with LIMA to the LAD and diagonal. He continues to do well several months out from surgery with no mitral regurgitation on echo.
Man, I'm so glad this patient had a good outcome, especially after Sina gave us all the mortality with this complication of MI. Thanks for guiding us through the case, Lefan.
Thanks, everybody.
Lefan, Sina, and Neil, what a crazy case and an amazing salvage. And I'm so glad that your patient is doing well. You took us from a chief complaint of dyspnea and uncovered real badness within this heart, acute papillary rupture, which, as you pointed out, just generally has an abysmal prognosis. But it sounds like with a rapid escalation of care, in this case, mechanical circulatory support when medical therapy was failing, quick recognition of the pathology, and then a great treatment plan with multidisciplinary team, your patient actually had the outcome we pray for when we have patients like this. So thank you so much for walking us through the case, giving us an overview of mechanical complications in MI, and it's specifically a deep dive in papillary rupture with acute mitral regurgitation. And I definitely appreciated that deep dive into the echo findings, because that can be very helpful in this case and as well as in all cases of mitral regurgitation. So thank you, team. You did a stellar job. What a masterclass presentation.
Thank you so much for having us. And now, for the expert CardioNerd perspectives and review segment for this episode, we're excited to introduce Dr. Jeff Bruckel. He is an interventional cardiologist here at the U of R that we all love working with. He is also Associate Program Director of our Interventional Fellowship as well. And we're excited to say that he won the Teacher of the Year award this year. So really excited to have him on our podcast today.
Hey everyone, this is Jeff Bruckel. I'm one of the interventional cardiologists from Strong, URMC Hospital, and I want to say thank you to our fellows for inviting me to participate in this discussion of this great case. So thanks everyone for having me. So this gentleman had a relatively dramatic initial presentation, and this is a circumstance where you need to be able to think on your feet to sort of quickly narrow down the differential diagnosis, because some of the issues that could be going on are potentially immediately life-threatening. So you really want to focus on things that you would need to identify and intervene on quickly. I agree that based on the description of the patient's symptoms, pulmonary embolism would be a top of the list in terms of concern. The one thing that you have going against that is the significant amount of pulmonary edema that the patient is exhibiting, both on physical exam as well as on his chest x-ray. Pulmonary edema is a relatively uncommon finding in pulmonary embolism, and so that's something that I would really, sort of push me to look for alternate diagnoses. Along similar lines, I wanted to make a comment on the use of a D-dimer in this clinical circumstance, which I think has limited clinical utility. A D-dimer is really useful in somebody who has low risk of pulmonary embolism, who you're looking to rule out pulmonary embolism. Finding of an elevated D-dimer in someone who has multiple clinical signs or symptoms consistent or potentially consistent with a pulmonary embolism, the finding of a negative D-dimer is not going to do much to sway you away, and the finding of a positive D-dimer is not really going to change your clinical suspicion at all. So, electing to obtain a D-dimer in this circumstance is really going to be not of much clinical utility. Based on the review of the patient's vital signs, I think it's readily apparent that this patient is in pretty bad shape. The one thing that's especially concerning is that the patient's heart rate is 130 beats per minute and sinus tachycardia. The presence of sinus tachycardia in somebody who you're evaluating for either pulmonary embolism or an acute coronary syndrome really carries with it a lot of prognostic weight. and can be used to identify patients that are at high risk for acute decompensation during the course of their illness. In this patient's particular presentation, the decision to get the CTPE, I'm not certain I would have performed the diagnostic workup in that order. As I mentioned before, the finding of pretty significant pulmonary edema that's severe enough to impact the patient's ability to oxygenate would really argue against the presence of a PE. I think, a quick point of care ultrasound, as the team ended up doing, would be one way to really sort of narrow down the diagnostic picture to either right or left-sided issues without the need for obtaining a CT scan of the chest, which is going to carry with it pretty significant contrast load that you may want to utilize doing something else, like potentially looking at his coronary arteries. Point of care ultrasound can definitely be a great bedside diagnostic tool. Point of care ultrasound machines on the market are continuing to improve and becoming more widely available. The quality of the machines in some circumstances can vary pretty widely. Some of the older machines did not have the ability to measure Doppler waveforms or get good color Doppler. So in some circumstances, that can really limit your ability to evaluate for some processes. In this case, for example, it would have been very useful to have the ability to have color Doppler over the mitral valve. That would have made your diagnosis immediately and shown you the severe mitral regurgitation. Whereas, without color Doppler, you're really left with trying to make some determinations based on the hyperdynamic LVEF. I would definitely agree that using point of care ultrasound, just like any ultrasound-based modality and formal echocardiography, you really need to be very systematic and thorough and do your same exam the same way every time. The other thing that's really important to keep in mind is that point of care ultrasound is going to be very good at finding findings that are there. I think it's less useful, for ruling things out. I think you need to be careful about completely excluding certain diagnoses just on the presence or absence of the findings based on point of care ultrasound due to some of the limitations and quality of the devices. One thing that I would add about this patient's treatment course is that, some patients like this, it's useful to have a low threshold for invasive assessment of hemodynamics. Taking the patient like this to the cath lab might allow you to make a more rapid diagnosis of this problem, especially with the use of ventriculography. You could pretty quickly see that there's severe mitral regurgitation, and the ability to obtain a right heart catheterization, allow you to measure the cardiac output and other hemodynamic parameters, would give you a way to risk stratify him and to help you decide which kind of mechanical support strategy would be best for this patient, or if he needs mechanical support at all. I think this is a good time to bring up the idea of a balloon pump super responder. So a balloon pump, although in most patients does not provide additional cardiac output that would be sufficient to resolve shock states, in certain subgroups of patients, there have been identified groups of cases where patients may have an exaggerated hemodynamic response to a balloon pump. And acute mitral regurgitation is one of those circumstances where simply by improving the patient's afterload, you can result in a substantial improvement in the patient's forward cardiac output. The other group of patients that tend to be balloon pump super responders are sort of normotensive cardiogenic shock patients that you see with advanced cardiomyopathies who wind up having a high MAP. So those patients that have not yet gone into a vasodilatory state, those patients also tend to respond very well to balloon pump counterpulsation via the same mechanism of afterload reduction. So you would anticipate that this patient should have a pretty good response to balloon pump therapy, although it turns out that he didn't actually have a complete response to the balloon pump and therefore was upgraded to a more aggressive mechanical support strategy. And really in this circumstance, pretty much any of the available mechanical circulatory support etiologies should make a substantial difference in terms of improving end organ function for this group of patients. Either mechanical support with an Impella device, as we ended up doing for this patient, versus using VA ECMO if the patient is in especially bad shape, would both allow for adequate improvement of the patient's cardiac output. And some of that is going to vary from institution to institution on availability of particular support devices and practice patterns, but really any of the available mechanical support strategies would work for him. So the angiogram in this patient is very interesting in that it does show kind of an ulcerated plaque in the mid-RCA, which looks like it definitely could be the culprit, although it has a kind of a torn up appearance with maybe some thrombus on top of it. The interesting part is that the vessel has TIMI-3 flow, and there's no abrupt vessel cutoff in any of the runoff territory, which you would expect for someone who has a completed MI. But I think the most likely scenario is that he ruptured a plaque either in that area or embolized a chunk of thrombus down distally into one of the more distal coronary branches and infarcted that territory, which is now subsequently recanalized. Clearly, based on the clinical scenario, you would not attempt to revascularize this artery, even though it's the culprit vessel, because you are planning on likely managing this patient surgically, as the team will go into in a little bit. I would also disagree a little bit with Sina's characterization of flow in the LAD. There's definitely a 80 or 90% lesion following the takeoff of a major diagonal branch, but I would characterize the flow as maybe TIMI-2A. The flow does reach the end of the vessel, and it's slower than normal, although not totally normal. I think it's grading TIMI flow is something that's very subjective and matters based on what's your contrast flow rate and how long you stay on the pedal. In this case, I do think it's probably a little better than TIMI-1. And then, again, the decision about whether or not we revascularize that artery is going to depend a lot on what the anticipated surgical management is going to be. And definitely we would leave it alone for now. I wanted to take a little bit of a deeper dive into the idea of PISA, which I find to be one of the most fascinating concepts in echocardiography and a very creative use of what you normally think of as an artifact. So PISA is entirely based on color Doppler assessment, which is a variant of pulse wave Doppler. And one of the issues with pulse wave Doppler is that there is a maximal velocity that pulse wave Doppler is able to measure. And after that velocity, the Doppler will start to alias, which means that instead of reading out a high velocity, it'll then become low again. The idea is sort of similar to looking at a wagon wheel on an old film. So if you're watching like a covered wagon go across the desert, the covered wagon's wheels might actually look like they're going backwards, and that's because of the difference between the frame rate of the film and the speed of the wheel. And so it's catching it at just the right time so that it looks like it's going backwards. So color Doppler, because it's based on pulse wave Doppler, you actually are able to measure the aliasing velocity, and it's given to you something called a Nyquist limit, which is shown on a scale, usually at the upper right corner of the screen during your computer color Doppler assessment. And you can draw out the limit of where that velocity line flips from one direction to the other. The advantage to that is essentially you're now able to calculate the velocity of blood in all areas along the sphere as the flow converges to go through the hole. So as blood sort of lines up and gets in line to pass through the opening, there's a period of laminar flow, and then the flow will become turbulent. And so in that region of laminar flow, the aliasing velocity will happen, and you can calculate the overall flow of blood in the dome of blood that's made up by that PISA dome. One thing that I think is really important to highlight about this case is the overall epidemiology of mechanical complications of MI, which vary incredibly wildly from institution to institution. A lot of it is driven by patient populations and abilities to access care. And we actually saw an uptick in the number of mechanical complications that we were seeing during the course of the COVID pandemic as patients waited at home with heart attacks rather than seek care immediately like they would have before. So it can be a marker of places where there is more limited access to care or more difficulties in obtaining timely care for MI. We've also seen a number of mechanical complications in younger patients who ordinarily you wouldn't think of as being as especially high risk for acute coronary syndromes, but because that perceived risk is low, patients don't think that they're having a heart attack and might wait to seek care. So we've seen all kinds of mechanical complications in younger patients as well, which is can be very unfortunate and very difficult for patients to deal with. The bottom line for dealing with all of these mechanical complications is to have a high index of suspicion for them as you bring patients over to the cath lab. This goes back to just overall fundamentals. Good physical exam, good clinical suspicion can help you more rapidly identify these problems, and that definitely changes your management strategy in the cath lab. Whereas, ideally, for most circumstances, you'd be focused more on reperfusing the vessel. Whereas for someone who's experienced a mechanical complication, the idea shifts more towards institution or evaluation for mechanical support and keeping them stable until they're able to have a definitive repair for surgery. So For cardiology fellows that are listening, definitely every single patient that comes to the cath lab, you should be listening for murmurs very carefully. I know that's really difficult in the emergency room where it can be loud and there's a lot of people around, but it's incredibly important, particularly for things like ventricular septal rupture, which are going to be really, really challenging to pick up on focus without a careful color Doppler examination. So thanks for our fellows for such a great presentation, and thanks for inviting me to lend my 2 cents to this conversation. Thanks, everybody. Bye-bye.
And finally, to close out this great episode, let us introduce our Cardiovascular Disease Fellowship Program Director, Dr. Burr Hall, so he can share his thoughts on our program. He is an electrophysiologist and a great mentor for each and every one of us. He is such a strong advocate for our daily education, and we just love working with him every single day.
Hi, everyone. I am Burr Hall, the Program Director for the Cardiovascular Disease Fellowship Program here at the University of Rochester. Thank you, Lefan, Sina, and Neil, for the excellent presentation on a patient with acute papillary muscle rupture. This patient was fortunate to receive such outstanding care from all of you. I learned a lot during this case presentation, including that Lefan plays the guitar, which I did not know. Our fellowship program at the University of Rochester is truly exceptional. We see a wide variety of clinical cases, serving a catchment area that extends down to the Pennsylvania border. With 6 fellows per class, our graduates pursue advanced fellowships as well as academic and private practice careers. We have a very busy heart transplant center and LVAD program, and we offer extensive training in critical care, including a 1-year cardiac critical care fellowship. Additionally, we provide significant research opportunities with 2 full-time research faculty members. Our location in central New York gives fellows the opportunity to care for patients in both urban and rural communities. We are excited about the upcoming fellow applicant interview season this fall, and if you decide to apply to our program, we really look forward to meeting you. Thanks again, and great job with the presentation.
Thank you for tuning in to this CardioNerd episode. The audio and editing for this episode was performed by me, Atefeh Ghorbanzadeh. I'm an intern in CardioNerd Academy House in Pullman and a research fellow at the Mayo Clinic. I invite you to check out our website for show notes and references. If you find this episode informative, please consider subscribing to CardioNerd on your favorite podcast platform and leaving us a review. It really helps us spread the word for our goal to democratize cardiovascular education. Finally, this podcast is not meant to be used for medical advice. The views and expresses on our show and site do not reflect the opinion or policy of our employers. All CardioNerd content is planned, produced, and reviewed solely by CardioNerd. Stay tuned for more engaging conversation and exploration on our upcoming episodes. And now, it's time to make like S2 and split.